our webinar now. We will start in about 2 minutes time. Maybe some background of today's talk. Today, our lecturer of the webinar is Dr. Katz. Dr. Katz is the head of the urology department in Zafed Medical Center, which is located in north of Israel. Dr. Katz is also a lecturer in Bar-Ilan University. And it's our privilege that we can have a lecturer that has experience using our system, but also the academic background. I would like to take this opportunity to welcome our guests. I think it's the afternoon time in Asia, morning time in Europe. We also have the Medispec team with us. We have Mr. Avner Spector, the CEO and founder of the company. We also have here the service team, the clinical team, and the sales and marketing. Mr. Effie in charge of Africa and the Asian market. Ms. Tanya in charge of European markets. Maybe a few formalities for today's webinar. Kindly feel free, and we encourage you to ask questions. You can use the chat area. We will gather all the questions and we will have a Q&A time towards the end of the webinar. And the session is being recorded, and we will share it later on in a few days' time. During the webinar, everybody is put on mute to allow a fluent lecture. Amit, what do you say? You think we can start?
I think we can start.
Okay, so I'm very excited to welcome Dr. Ran Katz. The floor is yours.
Thank you everyone. Thank you for the kind invitation and for the warm welcome and presentation. As you just heard, my name is Ran Katz, and I am the head of the Department of Urology in Ziv Medical Center in Safed in the north of Israel. And I have quite a lot of experience with shockwave lithotripsy in various machines. I come originally from Hadassah Medical Center in Jerusalem, Israel. It was the first institute in Israel, and for many years, the only one that had a shockwave machine. And we're going to talk today about a little bit about the development and the history of shockwave machines, about the current indications for shockwave lithotripsy, about recent developments, and we're going also to touch a little bit about the subject of the COVID-19 crisis and the impact that it carries on stone treatment worldwide. So let's go back to the essentials, and I'd like to take you to 1984 when Christian Chaucy presented first his classic machine doing extracorporeal shockwave lithotripsy. It was a real shock for the urological community. Until that time, all the procedures were performed as open surgery. I have to tell you that I never performed open surgery for stone, even as a resident in Hadassah in Jerusalem. At that time, we already had the extracorporeal shockwave machine. As you can see, this classic model, which turned out to be later on the classic HM3 model of the Dornier, was totally extracorporeal. The energy was sent from outside of the body and was focused with a narrow focal zone on the stone. All this was done under continuous treatment of fluoroscopy and surveillance. And so the surgeon performing the procedure and the technicians knew exactly at all times where the stone was located and whether it disintegrated at the same moment. Since then, a lot has changed, and we're going to go through some of the changes. We have to recall that until today, the concept of ESWL is crushing the stone into small particles, and those small particles need to be exploded outside. There are many technology advancements. There are only technological limitations to this procedure, and we're going to discuss this in detail. Just one thing before I go to the next slide. You have to remember and recall that this was all done underwater. Old ESWL machine had to transmit the energy to the body. And for years, it was my duty as a resident in the shockwave unit of Hadassah to fill the bath chamber of this machine, to immerse, I would say, the patient in hot water, enriched with salt and oil, to carry the shockwaves from the generator here to the patient and to the stone itself. Of course, we don't do it anymore, but I will show you some pictures, and here it is. This is the first model, the HM3, the classic one, a very large and cumbersome device. You have to put the patient inside within a bath of hot water, and you can use 2 cameras to locate the stone. The shockwave center is down below, and you have to position the patient halfway on his side when his flank region is deeply immersed in the water, while his head is up above the water, and that's a tricky business. So the shockwave will reach exactly the same spot that you wanted to go. It was not obvious. We had challenges like how to break stones which are distal, can we treat patients through the abdominal cavity. What happens if the patient is small or short? And I will show you later on some slides of pediatric ESWL. You take a 3-kilogram baby and put him into the water. Well, ever since we've developed and changed, and things have totally changed completely. First, we don't use the water anymore, just a cushion filled with a specific gel that is adhered to the patient from the flank region. All this is done under fluoroscopy. And the fluoroscopy when the patient is in the supine position. The fluoroscopy can be changed, the angle, the intensity, and give us a very good view of the stone. The patient position is rather fixed, but if in specific cases we are interested, we can change the patient position and place him on the abdomen. And this is mainly intended, as I will show in a few minutes, to treat stones in the distal ureter and even in the bladder. There are specific challenges here. One of the main concerns is always the patient's weight. Classically, ESWL sessions are intended to use with patients up to more or less 130 kilograms. And this is very good. This will cover the majority of your patients. But nevertheless, we still have patients which are more obese. They weigh more. It's more difficult to place them on the table. It's more difficult to take them off the table. That's one issue. And their body habitus. Patients don't just reach 130 kilograms like that. This means that usually they have a very big, even distended abdomen. And this increases the distance between the skin to the stone itself. And the more the abdomen is distended, the more the flank region is fat, then you're far away from the stone. If you're too far away, you will not be able to focus and point all your shock waves into a reasonable point, and this makes lithotripsy impossible. But again, it means that your patient is either extremely overweight or has a very unique body habitus, meaning that he's very short stature and very wide. Well, this is not your typical patient, but this is a challenge. Again, positioning the patient in various positions may help you overcome this problem. I already mentioned the point of stone location. Classically, ESWL is performed rather easily in the kidney, when the stone is one of the regions, either in the renal pelvis or more peripheral. But we can break stones in any level of the ureter, if we like. It's only a matter of positioning. For example, upper ureter can be dealt in the classic position when the patient still lies here on his back, and we point the focal zone from here to the upper ureter. The mid-ureter is a bigger challenge, and that's because it's often covered by the large bowel. The large bowel contains gas, and this does not allow the passage of the shock waves. But if you place the patient a little bit sideways and you push a little bit with the cushion, then his large bowel will fall medially, and this will expose the diastole of the mid-ureter. So it can also be reached. If we go further down, and I'll show you on other slides in a minute, Then we have the pelvic bones, which of course do not allow the passage of the shockwave. But for this, we can place a patient facing down, that means lying on his abdomen on the cushion and bringing the shockwaves from the front of the patient rather from his side or his back. The shockwaves need to be synchronized. And why is that? We have to recall that our shock is located in the region of the kidney, which is rather far from the heart. But the myocardial tissue of the heart is an excitable tissue, meaning that it is controlled by electrical current coming from the sinoatrial node of the heart. But if we touch or if we shock the myocard, it will generate its own new ECG signal. Now, this phenomenon is well known and often is meaningless. If the shock is not too strong, we may record once in a while an extrasystole of a patient undergoing ESWL. But have a look here at this EKG. This is a normal ECG of a patient. Now, this is the main part where the heart contracts. This is the QRS complex. Now, if our shock will hit the myocard at the same minute as the QRS, and we'll have it on the QRS, nothing will happen, the heart will work fine. But if we go to this segment between the QRS, and this is the T wave representing a repolarization effect of the myocard, and then we will get what we call the R-on-T phenomenon. Because if a shockwave will hit the heart right here, then we'll get an arrhythmia. This could be life-threatening. So, generally, we work in a synchronized mode. This means that our unit is connected to the ECG monitor, and we give the patient a shock wave exactly on the QRS. In young, healthy patients, often rather tall, where the kidney is far away from the heart, and especially when you work in lower energy settings of the ESWL session, then you can even work unsynchronized with a very low risk of any arrhythmias. But generally, it's preferred to work in a synchronized mode. Now, an interesting point when we started working with the ESWL machine is what do we do with patients with pacemakers? Would this be a problem to the patient? And I'll tell you right away that it's not only that it's not a problem, it's even an advantage. Because patients with pacemakers have a fixed rhythm, it's very easy to synchronize between the pacemaker and the machine. On the contrary, if you do a case with a regular patient and you do it under sedation and he feels slight pain or discomfort or is a little bit agitated, his heart rate will continue to change. And this may drive you crazy because you start with a rhythm of 60 per minute, then you go to 90, then you go to 80, then you go back to 100, and it will work. The machine will work fine, but the rhythm is constantly changing. It makes things much more difficult for you, more difficult to follow, and more difficult to expect when will you finish the case and ask for your next patient. If you have a patient with pacemaker, it's much easier. You know exactly where you are. How do we localize the stone? Now, the majority of kidney stones and ureteral stones are calcified, and this makes things much easier. Here's a classic case of a stone in the upper ureter of a patient. It is heavily calcified. You can see that it looks much like the stones, the bones of the vertebral column. Same intensity, same color. It's very easy to locate it. So if we use fluoroscopy, it's quite easy to do. What happens if the patient has a radiolucent stone with a low amount of calcium, rather low amount? It will be difficult to view by fluoroscopy. And then we have two options. One of them is doing a retrograde ureterogram. We can place a ureteric catheter inside the ureter, inject contrast material, and visualize the ureter, the renal pelvis, and the calyces as filled with contrast. Now, the stone itself will be visualized as a filling defect, for example, rather here or here, depends on the location of the stone. And then again, you can work with fluoroscopy. Many people will tell you, well, if you already insert something into the ureter, why do ESWL, do a ureteroscopy? And this is the answer. You don't have to use this at all. People are forgetting the possibility to do ESWL, shockwave lithotripsy, under the guidance of ultrasound. And ultrasound is quite effective, especially in the kidney and sometimes in the upper and the lower ureter. It's easy to visualize the stone. It's easy to monitor the stone. It is easy under ultrasound to demonstrate that the stone is disintegrating. And since no fluoroscopy is involved whatsoever, you can do it continuously and online. Now, as often when you work with ultrasounds, you need to have proper training and get experience. But once a surgeon is experienced with locating stones with an ultrasound device, he will find, and I guarantee that, he will find the need of fluoroscopy negligible. It's much more easier, it's nice to work with an ultrasound. I can tell you that the Medispec device that we use here in Ziv Medical Center is easily connected to the ultrasound, and we do it at all times. We follow the patients, and we can exactly change and point our focal zone very accurately with the guidance of the ultrasound. Now, what happens when we break the stone? Effective ESWL crushes stones to small fragments which are between 1 to 3 millimeters and to dust. The dust is washed away with the urinary stream. The fragments are being expelled by the patient, and often small fragments less than 3 millimeters will pass without any pain. Sometimes patients will note that they're expelling something out, and they will report it in morning grounds. They can tell that they saw some blood clots or something small, black and tiny coming out with them. But often this will be painless. If the fragments are too large and the fragmentation is incomplete, then patients may suffer from renal colic due to transient obstruction of the ureter. What are the main principles here? The energy setting. Usually work up to 25 kilowatts. You can work with less, and we often start with less, follow the stone under fluoroscopy or ultrasound, and once we see that it starts to move or to disintegrate, usually there's no need to go higher, but you can go up to 25. 25 kilowatts is quite a lot of energy. Now, the number of shockwaves per session is anything between 1,500 to 3,000 shockwaves. You don't need more than that. Often, most stones, from my experience, will start breaking with 1,000. You can completely disintegrate a reasonable stone, let's say 8 to 10 millimeter stone with a 1,500 shockwaves without any problem. And if you do want to do thorough work, treat more than one stone, or make sure that your stone is well crushed, you can go up to 3,000 shockwaves, and that's a reasonable amount of shockwaves. Above that, there is no real benefit. Usually, the field will become hazy and dusty because you already crushed the stones, you will not see too well, and there's no benefit in going more than 3,000 shockwaves. The rate is usually around 60 per minute, which means that about 25 minutes for 1,500 shockwaves. We can go faster, especially if it's synchronized with the heart rate. So if you have a patient with a heart rate of about 80, 85, then of course it will be faster. Once in a while, we have athletes who tend to be bradycardic and it will go slower, but still it's highly effective. Very, very rapid heart rates or very rapid crushing rates are not recommended because it takes time for the stone to absorb the energy and break. Meaning that if you compare 60 per minute to 120 or 130 shocks per minute, usually the 60 will be more effective. Faster rates are good, but it's fast, but they're usually weaker, and the stone needs time to absorb the shock, disintegrate, and then it is ready for your next shock. There were various attempts to do a dual, rather a single mode of shockwave lithotripsy. That means having two devices passing shock from one side and the other. It is possible. As I mentioned before, the stone needs time to come back and be prepared for the next shock. So there's no significant benefit to this. You may use it if you have a dual machine, it's fine. Most dual source machines can be also be operated as a single source, so you can have them. It's not a real benefit, probably. Again, you have to continuously image and be flexible with your procedure. You don't just point to a stone, locate it, and start crushing it, and that's it. You don't go to have your coffee. I mean, you can have your coffee with you, but keep an eye on the patient, keep an eye on the stone. As I mentioned before, the use of ultrasound makes it very easy to follow, to monitor. You can stop for a minute, adjust the location of the stone and your focal zone on the stone, maybe have the patient change his position a little bit and do a good work about it. The stone composition has a significant influence on your success rate. Most stones will contain calcium, others will contain more uric acid, and others can contain other materials such as cysteine. Now, cysteine stones, classically in cystinuria patients, are devils. These are very powerful, they're very strong stones, very difficult to crush. You will need more time, you will need more energy, and maybe do repeated sessions in order to crush them. On the contrary, uric acid stones will break very rapidly and very easily. And calcium stones are all somewhere in the middle. As I mentioned before, the more calcium in the stone, it may be more stronger, but it's more easy to locate, especially if you work with fluoroscopy. So there's a balance between a weak stone to a very strong, tough stone. The later one may be more difficult to crush, but often more easy to visualize. The triple D score mentioned here is a combination, is a score given to a stone, taking into consideration the distance, the dimension, and the density of the stone. The more far away the stone, the bigger the dimension, and more dense is the stone. So meaning that giving a higher stone, it's more difficult to crush, and your chances to succeed decrease. Now, these are the classic basics of extracorporeal shockwave lithotripsy. Why is the difference from the laser lithotripsy? What does it do that we don't do? Laser lithotripsy takes into account the fact that you take a laser fiber, you get close to the stone, you either touch it or stay in front of it a few millimeters away, and you activate the laser. And this may do one of two things. First, you can transfer directly energy to the stone, and then it may break. But the classical way of breaking stone is creating cavitation bubbles. It means that the urine just in front of the stone gets heated very rapidly and creates bubbles. And this causes an explosion. And the explosion is the energy that finally breaks the stone. But this is the same thing that may cause the stone to move. And it's very typical during laser lithotripsy, during ureteroscopy, to see that the stone is gradually pushed back by the repeated action of the laser until finally it may jump back into the kidney, and then it makes your simple ureteroscopy into a complicated retro-infrarenal surgery case, because you have to follow the stone, change your devices, and keep following it with the laser that will break it eventually, but will also take it far away from you. We can crush everything, but not everything is justified. This is a picture of a classic staghorn stone. This is actually a very old patient of mine from Hadassah in Jerusalem, and believe it or not, we treated all this stone with extracorporeal shockwave lithotripsy, but it took 7 sessions. So it is possible, but is not recommended. Repeated and repeated sessions of ESWL for a very large stone may succeed, but may increase the risk of renal damage. And of course, the stone will not evaporate. The patient has to expel all this outside, and this will mean that probably you will have repeated episodes of renal colic. It's too much of a stone burden. Such a large stone will be treated often by percutaneous procedure, meaning that we will insert a nephrostomy tube from the lumbar region, the flank region, right into one of the calyces of the kidney, and will suction out with a mechanical device all the stone. This is a totally different procedure. Currently, extracorporeal shockwave lithotripsy is indicated in stones up to 2 centimeters located in the kidney or in the ureter. So let's go back to the same stone that I showed you before. This is actually a stone of a 24-year-old male. He's thin, he's otherwise healthy. The stone is calcified and easily identified and easy to access for shockwave lithotripsy. In such cases, your stone-free rate of extracorporeal shockwave lithotripsy is equal to ureteroscopy. It means that if you take the patient, you just do a shockwave lithotripsy, extracorporeal, and you will be able to eliminate the stone just as well as ureteroscopy with lasers. It is agreed worldwide that for one session, a single session for a stone, the overall stone-free rate is higher for ureteroscopy. And many surgeons will tell you, I'm going inside, I see the stone, I crush it with the laser, I take out remaining particles, and that's it. It is true. There is a slightly better result of stone-free rate. The stone-free rate meaning the rate that the patient is stone-free totally. You will do imaging right after the procedure or 1 month after the procedure, and the patient is stone-free. There are no stones. So perhaps slightly better to ureteroscopy, but there are much more complications. You have to remember that ureteroscopy is an invasive procedure. You go through the ureter up to the stone, and then you crush it. Meanwhile, you can damage the urethra, the prostate. The patient may suffer from dysuria, from urinary retention. You can perforate the ureter with a ureteroscope, and never forget that particles during ureteroscopy tend to fly back and go into the kidney. Now, a surgeon may start the case with simple rigid ureteroscope in order to break the stone, but then we'll find it very difficult to follow the stone all the way to the kidney and do this angulation and try to locate fragments down here in the lower pole of the kidney. So it is well known that the stone-free rate is a little bit better, but complications such as ureteral perforation, renal colic, readmission to emergency rooms is higher after ureteroscopy. And we will mention this again when we talk about the impact of the COVID-19 crisis worldwide. As I mentioned before, we can treat almost any level of the ureter with ESWL. It's easy to get your focal zone here and here. It is possible to crush stones here. Again, the patient has to be in the prone position. He has to lie on his abdomen, and you can transfer the shock waves from this region all the way to the mid-ureter and distal ureter, all the way to the bladder. Well, here's another case, a 48-year-old female, healthy. She has a 12-millimeter lower calyceal stone. Her pain is intermittent. She has episode of renal colic. She was treated in the emergency room and discharged, referred to the ESWL clinic. The stone is not that dense. We use the Hounsfield unit of the city to determine the density of the stone. Now, bones are anything between 700 to 900 Hounsfields, and even more. Cystine stones may be 1,200. But often, partially calcified stones are within 500 to 600, and these stones are usually easy to crush with ESWL. So if we look at recent guidelines, for example, the EAU guidelines, the European Association of Urology in 2016, then a 10 to 20 millimeter stone in the lower pole of the kidney with normal anatomy and no unfavorable factors can be treated equally by ESWL or endourology. The thing is that if you treat such a stone with shock waves, you're totally non-invasive. Your patient lies on his back comfortably with sedation, and it takes about 35 minutes, and that's it. If you want to do this in endourology, you have to go all the way through the ureter with the chance of perforating or damaging the ureter, going with a flexible device down into the lower pole, and breaking the stone with lasers or pulling it out with a specific basket. It's longer, it's more time consuming. You have to use general anesthesia or spinal anesthesia. You cannot use sedation for such a case. It will take longer, and the equipment is much, much more expensive than an ESWL machine. And so again, guidelines from the World Journal of Urology ESWL is the treatment to be discussed as an option in all patients with renal stones of 10 to 20 millimeters. I was asked many times, what about possible side effects of the ESWL technique? Well, everything has side effects. Most of them are not dangerous. Let's talk and go through some of them. Well, the most common thing that you may see after a successful ESWL session is small hematomas over the skin. They're insignificant. They're being absorbed a few days after the procedure. It usually happens in high energy settings. And if your patient decides to move in the middle, what will usually not happen. But it really is meaningless, and you have to discuss it with your patient so you'll not be surprised. Do we see bleeding from the kidney itself? Well, at the beginning of the ESWL days, and we used to do CT scan, at that time it was very expensive, to see the kidney and see the capsular region of the kidney, whether there's any damage. There's a classic work from a Japanese group who did both CT scans and MRIs to patients and demonstrated that, yes, you may find subcapsular hematomas in the kidney after ESWL session, but these are always asymptomatic. This is not any significant bleeding. This is normal that if you apply ESWL to kidney, if you take the patient to the MRI unit and do an MRI, you will see small subcapsular hematomas. This is normal, totally asymptomatic, and meaningless. Can a patient bleed to death from renal surgery after ESWL? Well, practically not. This may happen. This has never happened, but it may happen if your patients will take anticoagulation during the ESWL session, which of course you will not do. We do not do ESWL session under aspirin and under any of the new NOACs, those medications need to dilute the blood after coronary procedures. And of course, you do not do lithotripsy under full anticoagulation such as Coumadin or warfarin. But otherwise, you will not see it. Retroperitoneal hemorrhage was reported. As a matter of fact, I reported a case almost 25 years ago when a patient had in one institution ESWL session. The day after he had a heart attack, he was admitted to another hospital. They did not know that he had ESWL session. They gave him full anticoagulation and streptokinase, and then he developed a retroperitoneal hemorrhage. Now, this is extremely rare. This is something that does not happen. It's an important point. When you do an ESWL session, mainly in patients who tend to be hypertensive, you may see a transient rise in the blood pressure. This is normal and can be related both to the ESWL effect and both to some pain before or after the procedure. It is well controlled with medication. It's never an excessive blood pressure. It's something that you monitor, and this is absolutely normal and has no impact on the patient itself. Most of your patients will report blood urine in the 24 hours after the session. This is normal. This is expected. And when my patient tells me, listen, I went to the toilet, I had blood urine, I say, good, it means that it works. So again, there's nothing to worry about. As I mentioned, renal colic may happen if the stone is not well crushed. If you break a 10 millimeter stone to two fragments of 5 millimeters, those fragments are small enough to enter the ureter, but big enough to be stuck in the way and cause significant rise in the intrarenal pressure and lead to renal colic. But if you crush the stone well, you take your time, you follow the stone, and you completely disintegrate it, this will not happen because the patient will pass very small particles and dust, and this will be non-painful. Is it worthwhile to do several ESWL sessions, not 7 or 10, but is it worthwhile to do retreatment, a second session? And the answer is absolutely yes. You can safely perform a second ESWL session on the same stone or a residual stone a few weeks after the first session. From my experience, often the stone will break easy. And this happens usually because the stone, as you may see it, in your follow-up visit, in the patient's follow-up visit, is not a stone anymore. Usually it's a cluster of fragments. When you break a stone quite well, sometimes fragments tend to get adhered together and get stuck. And if you perform a CT scan to control your patients, Well, the CT scan is very sensitive to stones, but it will not discriminate between a stone and a cluster of fragments together. And so, if the patient will say to you, listen, doctor, I see from the CT scan report that I still have the stone. What do we do? Do I need to go now for ureteroscopy or any other procedure? The answer is no, because it's very logical to do another session of ESWL, and this will probably break the stone very easily and cause the cluster of fragments to disintegrate, and the patient will be eligible to pass them spontaneously outside. Usually it is agreed, especially in Israel and in the UK, that after 2 sessions of unsuccessful ESWL, then you should consider ureteroscopy or other endourological procedures. But the concept here is, if one ESWL session is not successful enough, do not hesitate, offer another one, because often it will work. And still, it's much less invasive than doing an endourological procedure. What about children? Well, children have stones as well. I can tell you, I practice in Israel, and stone disease is endemic in Israel. We have a very high rate of stone cases here. Now I work in the north of Israel, and inside Israel, the majority of patients with kidney stones come from the north. And we have children in all age groups treated for kidney stones. Now, children are small. They're usually thinner, so it's very easy to point the ESWL machine and locate the stone, and very easy to place the focal zone on the stone. On the contrary, the smaller the children are, the more difficult it is to do endourological procedures. Now, I would like to point a very important aspect here. In most theories and most researches, the definition of children is not medical, but rather, I would say, legal. And that's it, because the legal age for children is up to 18 years old. So what happens if you have a 17-year-old patient? Well, the last 17-year-old patient that we treated here for kidney stones was about 6 feet high and weighed 200 pounds. Okay? So, because 17-year-olds are adults, they're not children. But in the literature, they will appear as children. So an endourologist will tell you, listen, the medical literature supports endourological procedures for children. Well, if 16 and 17-year-olds are children, then it's okay. But I have patients 1, 2, 3, and 5 years old. In many of them, you cannot do a complete ureteroscopy anyway. And if you damage the ureter of a very small child, he will be with you forever, because you will have to treat the ureter, you will have to operate him to fix what you've done. Children are very sensitive to ureteral injury. On the contrary, children pass particles very easily. So let me present to you here those 2 publications from 2019, one in Journal of Pediatric Urology and one in BMC Urology. And the first deal with shockwave lithotripsy versus ureteroscopy for the management of pediatric stones in the upper urinary tract. Okay? They concluded from a large series of children that children have less flank pain because they pass the stones easier and rapidly, better than adults, less ER admissions, that's after ESWL, less urinary tract infections, that's extremely important. If a child comes to you with a sterile urinary system and you do not place anything in the bladder or in the ureter, and you do the whole thing extracorporally, he will not get urinary tract infection. But we know that if you put a ureteroscope and you place a stent for this child and you do ureteroscopy, then the chances that on the next visit his urine will be infected is up to 30%. Although it's done under sterile, in a sterile environment and with sterile precautions, still the result of endourological procedures is urinary tract infection. And with ESWL, you do not get it. Okay? Of course, in ESWL, you need to use less anesthetics, because if you do a ureteroscopy in a child, he has to be intubated, he has to be paralyzed, and that's a much more serious thing than giving him deep sedation for ESWL. They concluded also that the clinical efficacy was the same. So to conclude this article, ESWL is equal to uroscopy in children. Ureteroscopy is more complicated, more urinary tract infections, heavier anesthesia, and more admissions to the emergency room and more pain. So ESWL is recommended for children and especially for the younger ones. The same here goes for the BMC Urology article from the same year. And they looked at other factors. And they looked at stone-free rates, OR time, and radiation exposure. And that's a significant issue. Most people who do ureteroscopy do it with almost continuous fluoroscopy guidance. That means they put the ureteroscope, they want to make sure they're in the right place, that they're close to the stone, and they will keep fluoroscopy their patients. There is a significant fluoroscopy time and a longer OR time in patients having ureteroscopy. This is the key. In children, you want to have the anesthesia as short as possible and minimize the radiation because they have a long life before them, and the effects of fluoroscopy and radiation on children is much more significant than on adults. So maybe with ESWL, your stone-free rate is a little bit lower, but the procedure is shorter, the anesthesia is much more simple, and you use less fluoroscopy. And as I mentioned, we have a lot of experience with doing almost complete procedures under ultrasound surveillance, and this is especially effective in children. Let's go even further. What about infants, not just children? I'm talking about patients 2 years old and younger. There's no suitable endoscopic equipment for them. They expel stones better than adults. And here's a classic picture. This was taken from Hadassah, where I worked. It's one of the cases that I did. This is a 2-year-old baby, okay, with a kidney stone. At that time, we had the classic ESWL machine of Dornier with the hot water, and we placed him in the water, and we crushed the stone. Today, it's much easier because what we can do is give the same kid deep sedation, place him supine on our Medispec machine, and do the case, and it will work very well. Okay. Now let's talk a little bit about the COVID-19 pandemic and the impact. As you know, the COVID crisis is worldwide. I can tell you from my experience as well as others, it has also significant impact on, what is colors? It has also significant impact on the healthcare system in general. It means not only that patients are sick and have to be hospitalized, it means that other procedures are postponed in order to free the medical staff to be available to treat the COVID-19 patients. So you have to postpone cases, elective or semi-elective cases. And the question is how much and how long can you postpone them for? Is there a risk? How long can you take a patient with a ureteral stone before the kidney will suffer? Another issue is, what is the risk for the staff? If you do an endourological procedure, you stand in front of your patient, you take a scope, you go through the bladder, up to the ureter, go to the kidney, you use irrigation devices, and sometimes the patient presses, and this means that urine or irrigation fluid is often expelled on you. So you may get splashes. Now, this does not happen always, but I don't see any reason at the era of the COVID-19 to wait that the COVID-19 patient with a kidney stone will urinate infected urine right at your face. By the way, the COVID-19 is detected in the urine. You can find COVID-19 in the urine. It was never cultured from urine, so we're not aware of any patient with COVID-19 urinary tract infection. But one of the main sites of the COVID-19, the main site that it enters your body and adheres to your body are the ACE receptors. And the ACE receptors are part of our blood pressure system, and the majority of them is located in the kidney. So the kidney is highly infected with COVID-19. So I go and ask myself, why do I need to risk myself or my staff with the possibility of any aerosol or splash-causing procedures when I can do the same thing, non-invasive, extracorporeally? So maybe it is not such a bad idea to do ESWL. Now, I can tell you that now we have now in the north of Israel a significant pandemic of the COVID-19. All the villages around us are filled with COVID-19 patients, but still they have kidney stones. So we wait, we do not operate emergency on COVID-19 active patients, but you always have it in mind. So we check the patients who come to the hospital, make sure they do not have COVID-19 during the serology test or the other test, but they are of limited efficacy. Do I want to risk my staff? Absolutely not. So I can tell you that next week when we do our next ESWL session, we have 5 patients for next Wednesday morning, that not only that we will test them, all the patients will have ESWL and none of them will be referred to ureteroscopy. I'm not doing an invasive procedure if it's not necessary in the COVID-19 era. And here's a very interesting publication, very recent, from the Journal of Urology. As a matter of fact, it will be published next month, but it is already available on the internet. And that's a very nice review coming from the United States, from the Michigan Urological Surgery Improvement Collaborative, the MUSIC group. And they looked at what happened to kidney stone care and the COVID-19 pandemic. And they're going to tell you what I just told you from my experience here. There are challenges here and maybe even opportunities. There's a strict restriction of the surgical care. Patients have to wait longer with stents because you don't want to treat them, or you cannot treat them because your operating time is limited, because all the hospital resources are going to the COVID-19. But they looked at their patients. They also prefer to do ESWL. And when they looked at it, they saw with ESWL patients, they have less emergency room visits than ureteroscopy. ESWL, absolutely extracorporeal, no stenting. Patients reported better quality of life. It can be done, as we mentioned before, then with sedation. No intubation, that's very important to the anesthesiologist today. Anesthesiologists are very reluctant to do intubation now when a patient may carry the COVID-19 because it's right in their face. So there's less exposure to the staff to aerosols, we just mentioned before. There are strengths here, the ESWL, the sedation, the low rates of the emergency room visits. There are opportunities here. Patients education, appropriate education to both staff and other doctors about the appropriate use of ESWL, taking it back, saying, look, something happened here. We have the COVID-19 pandemic. We can go back to the classic treatment of ESWL and offer it to our patients with better safety. And I think that's a very important point. As I mentioned, we do ESWL sessions now, and we prefer them to ureteroscopy, especially in this era. Oh, just a minute. Now, sometimes people ask me, listen, isn't it a very old technique? Isn't it a little bit outdated? Because everyone who's doing ureteroscopy and endourology will tell you, listen, ESWL is a little bit outdated. What do you answer these people? Well, I always do. My father is an engineer, and he's been running factories of the Israel military industry for the last 40 years. And he showed me this once and told me, listen, this is a modern hammer. This is a 3,000-year-old hammer discovered in Syria. Can you tell the difference? It's minimal. It's the same hammer, it's the same concept. You have a head and a handle. So here it's wood covered with leather. Here it's a stone, a strong stone, and here it's metal. But otherwise, more than 3,000 years have passed, and no one changed the hammers. And the reason is because it works. You don't need to change the thing that works so well. The ESWL is well known, it is safe. That's why it appears in all the guidelines. It's easy to use, it's easy to train, including both technicians who can work for you. You know, endourology, you cannot have a technician doing a ureteroscopy or helping you. You can have a nurse, a scrub nurse helping you in a procedure, but you cannot have an ESWL technician. But with ESWL, you can have a technician helping you, you can have some technicians helping you together, and you can do many cases, even do simultaneously if you have two machines. The ESWL machines are now, they're modern, they communicate well with all the modalities such as CT scan, ultrasound, they're portable, not as they used to be. Many people still recall the old, as I showed you, the Dornier, HM3, and equivalents, which are very heavy, two rooms in your clinic, which is, of course, very, very crowded. And this is not the case anymore. The modern ESWL machine, the Medispec that I work with, is light, it's portable, it's very easy to use, and very user-friendly, I have to say. So to summarize, I would say that the ESWL is reliable and efficient. It's not a dishwasher. You don't place your patient in an ESWL machine and expect it to work for you. It's an accurate technology. It requires knowledge, training, and experience. When you do an accurate work, the stone fill rate is similar to endourological procedures with a lower complication rate and less dose of irradiation. It is much better for children and especially for infants. You can optimize and should optimize it to each case, your treatment, take into consideration the stone burden, the stone location, the anatomy of the urinary tract, the patient body habitus, previous treatments that he had, and under these circumstances, ESWL is highly effective, and from my point of view, it is here to stay. So this concludes my talk. I'd like to thank you again very much for listening and for the kind invitation to lecture, and please feel free to ask me. I'll be happy to answer your questions.
Thank you, Dr. Katz, for the enlightening and also entertaining presentation, because, you know, with this medium, it's hard to see the responses, but we did see there is humor, some humor also in the presentation. And I think we didn't get a lot of questions because I think you touched or covered most topics. So we appreciate it very much. There are some comments and also some questions from my end. The first question is do you think that renal stone is a disease that it's fading away, you know, modern times, and more, you know, using more drugs, or this is something that will be here for many years ahead?
It's here to stay, and I'll tell you why. Because first, there are two main reasons for stone disease. One is not drinking enough water, obviously. You know, especially we see it here. We live in a hot country, hot climate. People are going often dehydrated. Their urine is heavily concentrated. They create stones. Now, modern life brings nice things like air conditioning, and you do a lot of work from home. You work with Zoom. You're less outside. But this does not change the rate of stone disease, because this causes you to drink less. I mean, you don't do more effort, so you stop drinking, but still you go with the same concentrated urine. The other issue is genetic tendencies and genetic disease. We see here many families, it's worldwide known, but we see here many families who have a transfer from one generation to another, the tendency to create stones. In many of them, you can locate and identify specifically a specific metabolic problem, such as hypocyclaturia, hyperoxaluria, cystinuria, and other diseases. And well, those patients are not going anywhere. On the contrary, they multiply and they pass it from one generation to another. So stone disease is here to stay. Obviously, the better we treat the patient, then the more stone-free he will remain for longer periods, but patients live longer. And you have to take into consideration that when a patient comes with a stone episode to the hospital, even if you treat him, the annual risk of another episode is currently anything between 10 to 12%. These patients are chronic patients, and they tend to come and recur. Now, if you give them proper medical therapy, after and only after you clean their kidneys from stones, you may decrease the rate of stone recurrence. You give them appropriate salts, they keep a high intake of fluids to dilute the urine, it may work, but still they will come back and they will transfer this tendency to their offspring.
Okay, so thank you for the answer. Let me read one of the comments from the audience, coming from, I think, from South Africa. My only comment so far would be that you should not argue that ESWL is better than laser. It should be a minimally invasive first option for a single or two small to large stones before laser. It gives the option of placing stent in the same session if the stones do not show obvious signs of change. That is our approach when we have kept ESW relevant.
Mm-hmm. Well, I absolutely agree. I'm not saying that it's better than. I'm saying that it has its unique features. If you consider many, as I said, many articles and many doctors look at the stone-free rate. Well, if you compare it to the treatment, a single treatment of ureteral stone, then the stone-free rate of ESWL is less than for ureteroscopy. But if you take the whole picture in terms of readmission, emergency room visits, pain, urinary tract infection, ESWL is better. So I'm not trying to argue that it's better than ureteroscopy, but it has its own unique features, and you have to do everything and have both modalities in mind.
Okay, let me read the second comment.
Donde están haciendo todas las preguntas. No,
I also think when you come to theater,
desde Filipinas, desde Sudáfrica.
Let's try to mute this.
Sí, Jorge, te oigo, sí.
1 minute.
Okay, so the second comment, I will repeat it. When you come to theater, the patient must have a CT and a plain X-ray on the morning or previous afternoon of admission, so you know where to look for the stone if you are dealing with a radiolucent stone. The CT does not have to be done on the day, even a few days before.
Well, this is a very important issue. Thank you for raising this question. This is true for any procedure for stone disease. When you work in a big center and you get referrals, you see patients coming with outdated X-rays. Patients may be sent to you with a CT scan done 2 months ago. And then sometimes you would take them to do ureteroscopy and get a white ureteroscopy. You go in and the stone is not there anymore. So first, in any case, not only in ESWL, both in ureteroscopy and so, you have to make sure that your X-rays are up to date. It is a common practice in many services to do abdominal plain film in the day of the lithotripsy just to make sure that the stone is in the same position, and if it is a calcified stone. If it is not a calcified stone, if it is a radiolucent stone, then you can either do in ESWL a retrograde hyalography, make sure and verify where the stone is, and then point the ESWL machine to this point. Or, as I mentioned before, especially if the stone is in the kidney, we do a lot of work with ultrasound, which is online. The patient is positioned, you scan it with the ultrasound, and then you can place your focal zone exactly on the stone immediately in the right location. But again, this is true for any procedure, not just for ESWL. The same goes for ureteroscopy.
Okay, the next question is, besides clinical considerations, can you say that ESWL is more economical for patients than laser?
Absolutely, absolutely. Listen, there's a lot of debate about, I run the department, and one of the biggest challenges is convincing the administration to buy me more and more endourological devices. Because again, one of the things that they will tell you right away is, why do you want to buy a ureteroscope, which is extremely expensive, and laser fibers, which are single use, when you have the ESWL machine? Now, if you look at it head to head, you have to recall that ureteroscopes usually work up to 40 procedures, and that's in the best places. Currently, there are even single-use ureteroscopes, which cost about $600, because uroscopes tend to break all the time. Now, one ureteroscope is usually $6,000. Any attempt to fix a broken ureteroscope is $3,000 and up. Laser fibers are single-use, and also about $200 a piece. And this makes endourology rather expensive procedure. Now, it depends. If a patient has this kind of insurance that would cover it, well, that's one issue. If he doesn't, then he's in a real problem. Mostly, if you take a modern ESWL machine, then an ESWL session is significantly cheaper than an endourological procedure for the same stone. Take into consideration that you have to put stents, that you have to retrieve the stents later. That means the patient will come again for another visit, okay? I can tell you that for a while when I went to Jerusalem, there was a pilot with the Ministry of Health of giving one price for one stone. That is, the patient comes to you with a 10 millimeter stone in the kidney, and you need to take it out. Now they said, we don't care how you do it. Open surgery, endourology device, ESWL session, do whatever. But as long as the stone is there, you will get a fixed price, let's say 10,000 shekels, which is about $2,500, to take out the stone. And all the rest is up to you. If you do 3 ureteroscopies, 2 ESWL sessions, open surgery, whatever, just get it over with. Any complication is on you. And at that time, we showed that the ESWL was the most cost effective because we just did extracorporeal shock waves and collected the money. Okay, so you have to take it into consideration. Per procedure, per one procedure for one stone, usually endourology procedures are much more expensive than ESWL.
Okay, thank you for this answer. How are we with time?
We are an hour. The
Okay.
session is already an hour.
So I think we will break here for the 1 hour. Dr. Katz, I would like to thank you again. We enjoyed the lecture very much. And I also would like to thank our audience for their patience. I know it's not easy to do the webinars these days. Please stay tuned. We will have more webinars ahead. We will publish that through our social media. And from Medispec to everybody, thank you again, and bye-bye.
Thank you very much. My pleasure.
Thank you.
Bye-bye, everyone.